the saturations actually went up yesterday itself. Once we were at this stage, the saturations went from 70%, which you saw, to about 90 to 93%, and the femoral artery saturation went up to I think 95%. We waited here and then we de-screwed. Next. You can see how this device is sort of released. Next. Go minus. So you can see at this point the flow has reduced markedly, but there is a small flow to the other branch. Next. Now I tried pulling this back and seeing how much can I go back, but there was a risk that I'm going to occlude that normal vasculature of the lung. So we thought we'll deploy the device here. The saturations were already up more than 90%. Next. Just hold on here. So this is how we release the device. We give a counterclockwise rotation on the string, on the cord cable, and then this just dehooks. It's sort of a screw, and the device stays there. Next. And this is next. And this is the final result which we got. Most of these fistula is closed. The saturations were up to more than 90%. Can I have a look at the saturation here? Just show it here. We got the patient here. You can still see the saturation is 93%. The PA pressures were around 60 plus and went down to 40, 44. And the gradient across the mitral valve was sort of 36 millimeter mercury initially. I'm sure it must have gone down. The heart rate, as you see, is just 92. At the procedure time, it was 127 because there was so much of shunting. And the patient is hemodynamically stable. He's now planned for surgery, mitral valve surgery, tomorrow morning. And so I think this is a good demonstration of two things. One, how we can, it's a rare case of pulmonary AV fistula with mitral stenosis. Otherwise, this sort of age, we normally, with this sort of clubbing, we think of a tetralogy physiology. Second, this patient actually, we could avoid a lobectomy and we could just treat by a Amplatz vascular plug, which this is not possible with coils because most of these coils tend to go very distally. We have to put a lot of coils and there is a risk that they can flow into the pulmonary vein, which is like 26 millimeter in diameter. Third, the very important thing, like tips, is when we got a 9 French guiding sheath for a device which goes in a 6 French guiding sheath, it was impossible to get the device up. And this was because the device was actually, it's a self-expanding device, so it was actually expanding and releasing, it's trying to release itself, and there was a lot of friction within the 9 French sheath. And when we went through a 9 French sheath, which has a lower inner diameter, this device actually went straight and did its job, and the saturations were up, and the patient was fine. The patient is actually walking today. We got him back just to show you this patient. You can see the saturations. It's about, can you focus on this? The saturations here are 94%. The patient is symptomatically better. You can see the heart rate, which is 92, and you can see the face of the patient. He looks very fine. Jawan dikhao. And just to show you again the type of, the cyanosis is gone. The cyanosis, what you saw in the initial picture, is now all very, very much less. And if you see that he's got a clubbing, but the cyanosis is very, very low now. This used to be a blue sort of extremity in the night. So this is all about this case. Now I have Dr. Ganju, who is going to operate this patient tomorrow for the mitral valve stenosis. It is actually his patient. And I have my colleague, Dr. Malik, who was very helpful, and he was my colleague. We did the case together in the night, 3 o'clock in the night yesterday.
Well, Dr. Khanna, this is Dr. Mishra here. First of all, I must congratulate you to work so late at night and look so fresh the next morning. And we all appreciate that the patient has really remarkably recovered after this procedure, though it has still residual shunt we can see, but that doesn't make a great deal of difference. What makes difference is saturation is good, heart rate is settled down, and patient looks better. Several points you have made are really practical, very important. But again, there seems to be more than feeding vessels to this AV malformation if you see on the angio. Yeah,
there are more feeding vessels, but I mean, one that we didn't have the vascular plug of the right size to seal that. There's one more vessel only actually, if you see. Can I go back on this? And that actually, if we embolize proximally, it has a lot of lung parenchyma, which is supplied by that pulmonary artery. Pura khol do usko.
Now, would you consider attempting
So
that until
what
later
we
date?
consider, since the saturation is up to more than 94% and the shunt has come down to less than 1.5, third, the patient is fine, the heart rate is fine, we would just consider it as a, as a pulmonary fistula of this sort. If we had it isolated without mitral stenosis, we would have left it. But it is very simple to embolize that branch, go distally and have the right sort of device, right size of the device and embolize it. So that's not a major problem, but we thought we will stop at this stage and then see, and if required, we will embolize that other vessel distally.
Any questions, please?
Now, if I may offer a comment.
Yeah, sure.
Regarding this additional branch which was not embolized,
Right.
it may happen that the branch enlarges in the due course of time and you may have to go in again.
Yeah, we are totally prepared to go in again. The thing was, 3 o'clock in the night, the lab, we didn't have the other device. And when we saw the CT, we didn't anticipate that, there's another branch which is supplying, because it was a mesh on a CT, we couldn't see that there's another branch which will require this sort of a plug. So we have the plug ready, we can do it even today. We know we have learned our tips and tricks that we have to go through a 6 French sheath or a 8 French guiding catheter, not a bigger sheath, and it would be very easy to deploy the device. Hopefully we may do it if required, and we have that understanding that if he requires, we will definitely go ahead and embolize this. But the aim to show this was, this is a unique case where we have a combination of AV fistula with such a deep cyanosis with mitral stenosis. Second, that the use of this vascular plug, one vascular plug seals most of the thing, how the saturation improves immediately after sealing this. And fourth was that tip, that we should actually take a adequate size sheath to deliver the device rather than an oversized sheath. Otherwise, it's very difficult to advance these devices.
And I suppose another point to add, better is the enemy of good. Sometimes if you have decent result in emergency situation, you should just settle down, then leave things for other day.
I have a comment on the first case, EVAR, for abdominal aortic aneurysm. We saw the films before deployment, the left internal iliac artery was occluded, and the predominant supply of the pelvic floor was the right. And after deployment of stent graft, we occlude ordinarily the lumbar arteries and the right internal iliac artery. So I give concern about this patient has high chance to develop pelvic floor occludication, and I would suggest to do some revascularization of the right internal iliac, like a short bypass from external iliac to right internal iliac.
To be frank enough, that was a concern I had too, occluding both the internal iliacs. The only one advantage is that the left internal iliac has been occluded for some time. So just acutely, if only one iliac gets occluded, one could be a little optimistic that the patient doesn't develop too many complications.
Mr. Chairman, we have totally run out of time for this presentation. We will have to now move